Hi, I'm Jeff Klein, editor of RadioGraphics, and today we have with us Dr. Michael Wells from the Mayo Clinic Department of Radiology, who is the author of one of our featured papers in the current July 2018 issue of RadioGraphics, and his paper is entitled Computed Tomographic Evaluation of Acute Gastrointestinal Bleeding. Dr. Wells, welcome to our podcast.
Hello, Dr. Klein. Thanks for inviting me to talk.
Great. So Michael, your paper addresses a fairly common problem that's encountered in many hospitals, which is that of acute gastrointestinal bleeding, and one where imaging clearly plays an important and significant role. Can you help us understand how these patients are typically evaluated clinically and exactly where endoscopy and imaging play a role in the evaluation and diagnosis?
Yes, this is a common problem. Most of the patients that we see with this develop acute GI bleeding as outpatients, and they're coming in through the ER. Not uncommonly, though, we see patients who are already hospitalized for other reasons, and they develop acute bleeding as an inpatient. Regardless of where this bleeding starts, they're all in need of an urgent evaluation. Most of the time, these acute GI bleeding episodes are going to stop by themselves, and they can go on as outpatients and being evaluated on a non-emergent basis. But some patients are going to develop profuse bleeding. They'll develop hypotension. They're at risk for potentially lethal complications of that hypotension. And so when they come in, the first thing that the ER or hospital staff are going to do is try to evaluate them to see if they're hemodynamically stable. If not, they're going to undergo resuscitation. If that can't be done on the floor or in the ER, almost all of them will then go to the intensive care unit for a more aggressive resuscitation. While that resuscitation is ongoing, they're also going to have a clinical evaluation to try to determine where this bleeding is coming from. And they're just going to try to divide this into either an upper or a lower source of bleeding. And upper source of bleeding being proximal to the ligament of Treitz and lower being distal. Signs that they'll have that this is an upper source of GI bleeding are going to be a hematemesis. If they've placed an NG tube and they have a positive aspirate, that's going to obviously indicate upper GI source. And patients who are coming in with melena. And so melena is blood that's been in the GI tract for several hours, and almost all of it's coming from the upper GI tract. Conversely, patients who have lower GI bleeding are usually going to be presenting with hematochezia. And so the clinical evaluation is good, but it's not perfect. People who have a positive NG tube aspirate, that's good for saying they have an upper GI source. But if it's negative, it's really not adequate for excluding upper GI source of bleeding and saying they have a lower GI source of bleeding. Patients who have hematochezia usually have a colorectal source of bleeding, but if it's a fast bleed, they can still be bleeding from their upper tract and having bright red blood per rectum. Once the clinicians have a handle on their hemodynamic stability, they have an idea of how fast this patient is bleeding and an idea of where it's coming from, that's going to guide the subsequent diagnostic evaluation. What type of evaluation they're going to do and how urgent it's going to be. For upper GI bleeding, almost all these patients are going to go to upper endoscopy. And the reason is that EGD is highly successful for both identifying the cause of bleeding and for treating it. And so for upper GI bleed, radiology is only going to play a role if we either can't go to endoscopy, maybe the patient's got significant comorbidities, maybe they have a large volume of bleeding or are unstable, or if they've done endoscopy and it's either non-diagnostic or has a negative result, but we're still suspicious of an upper GI bleed. Lower GI bleeding is a little bit more complicated. Again, the default pathway leads to colonoscopy, but we can't go straight there. These patients have to have a prepared colon first. And so unprepped colonoscopy is not very effective, and it's not recommended by the American College of Gastroenterology. And so patients with lower GI bleeding need to be admitted. They have to undergo a colon prep before they can get to colonoscopy. And you can imagine patients who do get admitted for this, they're sick, often admitted in the middle of the night. And those colon preps have variable results and are often unsatisfactory. And it leads to a poor quality exam when they do get to the colonoscopy. And that opens up the door a little bit here for radiology to play a role, potentially as a first-line diagnostic modality in these patients with lower GI bleeding. So clinicians coming with a patient who they think is actively bleeding quite fast, and they're not sure they're going to make it through their colon prep. They'll often go to fluoroscopic angiography or Ct Enterography before attempting colonoscopy.
Great. Well, thank you. So, Michael, let's briefly discuss the traditional methods of radiologic evaluation that are usually employed in patients with GI bleeding, which has been traditionally scintigraphy and angiography. And we can also look at figure 2, in which you provide sort of a flow diagram of the evaluation of acute GI bleeding. Could we take a look at that figure?
Yep, so we'll pull that figure up. And so in figure 2, what we're looking at here is just an example algorithm for a workup for a patient who is suspected lower GI bleeding. And so the algorithm here that starts off with some of the things we've already talked about, the clinical evaluation. And as we go to the right of the diagram, patients who are stable and likely to make it through their colon prep are going to be admitted. They'll get that colon prep and hopefully go on to a high quality colonoscopy the next day. Patients, on the other hand, who are unstable or who aren't responding appropriately to resuscitation, they need an emergent diagnostic evaluation and treatment. And so they'll go to the left of this diagram and they'll go to fluoroscopic angiography, which is perfectly suited for this purpose. It can be instituted rapidly, and not only can they diagnose the cause of bleeding, but they can treat it all in one setting. Fluoroscopic angiography is relatively less sensitive for bleeding when compared to other radiologic methods. So the reported rate of extravasation that can identify is about 0.5 milliliter to 1 milliliter per second of bleeding. And that compares to CT angiography, which is reported around 0.3 to 0.5 milliliters per second. And then the most sensitive would be technetium red blood cell scintigraphy, which is reported as low as 0.1 milliliters per second. Now, the relative insensitivity of fluoroscopic angiography for identifying bleeding typically isn't a problem because we're using this in patients who we think are bleeding rapidly and have a large volume of bleeding. Once they're able to identify that bleeding, then the other strength is that we can treat it. And so bleeders can be treated with either permanent blockage of vessels using coils or beads. It can be blocked temporarily with gel foam, or they can even infuse vasoactive medications to try and treat it.
Sure.
The limitations of fluoroscopic angiography are it's invasive, need a vascular route to get to the source of bleeding. So patients who have bad atherosclerotic disease or maybe variant anatomy could represent an impediment to evaluation with fluoroscopic angiography. In the center of this diagram here is CT angiogram. And so this is particularly useful for a clinician who has a patient where they think they're actively bleeding, they think they're bleeding fast, but they're not quite sure that this patient is going to make it through a full colon prep, and they're also not sure this patient needs an emergent intervention right now. And so this test can really help them with that decision. If they undergo a CT angiogram and they have a positive result, we'll hopefully be able to see the source of bleeding. And since we can evaluate the entire GI tract in the abdomen, we can tell them right where it's bleeding from and hopefully also get some idea of what's causing the bleeding. In addition to that, we're going to get other information that's useful. We're going to outline the anatomy of the GI tract, and so we can tell the clinicians if there's abnormal postoperative enteric anatomy or variant anatomy that'd be important for endoscopy. And we can also evaluate the vascular system to see if there's disease or altered vascular anatomy that'd be important for fluoroscopic angiography. So in a positive test, we get a lot of information, and that's going to allow us to choose the most appropriate next modality for intervention, whether it's angiography, endoscopy, or surgery. Now, on the other hand, if the patient happens to have a negative CT angiogram, that's also very helpful. So a negative CT angiogram gives us some good prognostic information. And a patient with a negative exam is unlikely to need an emergent intervention during their hospitalization. And so that makes us much more comfortable that we can admit this patient, attempt a full colon prep, and then go on to colonoscopy. And that'll be the route that most patients will use. And so I've tried to indicate that here in this diagram in the right lower corner here by drawing a solid arrow there to colonoscopy. But there are also several other possible options. These patients are complicated. They often have a prolonged history of bleeding episodes. So often intermittent, they've undergone several different exams. And so they come along with a history where colonoscopy might not be the best choice. And so say a person is coming in, we've got a negative CT angiogram, so we know they're bleeding, but we don't know where they're bleeding from. If they've had an upper and lower endoscopy relatively recently, well then maybe a triple phase enterography would be an appropriate evaluation because we're very suspicious of small bowel pathology. Patients who have slow or intermittent bleeding, a red blood cell scan might be the best choice. Number one, because it's the most sensitive test that we have, but also because we can inject labeled red blood cells and look for 24-hour period. And so that makes this a great test to look for these slow intermittent bleeds. Problems with red blood cell scans are that they're not available everywhere. Depending on the institution, it could take a few hours to get the test started. And we know that the longer we wait to start a test looking for bleeding, the less likely we are to find it. And it's relatively limited anatomically to tell where the bleeding is from. But some institutions have the ability to acquire this data with computed tomography, which greatly improves anatomic localization. And the last option that I put here in the figure, DAE stands for device-assisted endoscopy. And so double balloon or single balloon endoscopy, and these are great techniques. They can assess the entire small bowel. They can both do a diagnostic evaluation, and they can intervene on pathology when they see it. Problems with those are that they're relatively time-consuming and expensive. And we also have CE stands for capsule endoscopy. Capsule endoscopes are beneficial in that they have a high diagnostic yield for finding pathology in the small bowel. However, again, it's a several-hour delay to get that test started, and it might be a day or two before you get the results.
Sure. That's great. Thank you. So moving on to the focus of your paper, let's talk a little bit about computed tomography, which I think, as you've stated, provides significant advantages in the evaluation of these patients. You've discussed the role in the assessment of GI bleeding for CT, and in particular, the two methods that you describe in the paper are those of Ct Enterography and multi-phase Ct Enterography. We'll look at figure 1, which I think illustrates the use of Ct Angiography for the evaluation of a patient with recurrent GI bleeding. So let's take a look at that figure now.
Okay, so we'll pull that figure up. And we talked a little bit about the role of CTA in the figure 2, which we just discussed. But to compare a little more CTA versus multi-phase Ct Enterography, there are important protocol differences in those. When we're using Ct Angiography, we're using this primarily in patients who we think are actively bleeding, and that's what we're looking for, is the active bleeding source. And so the protocol is really designed to get the patient on and off the scanner and get a result to the clinician fast. And so we're not going to give people oral contrast in that situation. We don't want to slow things down for that. We're going to give them a relatively dense IV contrast bolus so that we can see this extravasation. And we're going to do a lot of reformats on the images to try to best identify any small sites of bleeding or pathology. Multi-phase Ct Enterography, on the other hand, is really a protocol designed for patients who are stable and who are outpatients. They've also typically had negative upper and lower endoscopies, so we're very suspicious that they have a small bowel lesion. And for enterography, we're not so much looking for active extravasation, but we're trying to optimize our evaluation of the small bowel wall and look for pathology that exists. For that protocol, the amount of oral contrast that people are administered varies by institution. We give people almost 2 liters of fluid here, and that takes about an hour to get in. And so in a rapidly bleeding person who could decompensate, we're not going to use this test to get a fast answer back to the clinician. But in someone who's relatively stable and who's able and willing to tolerate the oral contrast, Ct Enterography is a great choice to use even in an acute setting. Looking at this figure, this is a really complicated patient. It was a 56-year-old male. He had a history of hepatitis C. He had known gastric varices and chronic pancreatitis. And he presented a number of times for upper GI bleeds. And so repeated endoscopies had shown that he had known gastric varices. At one point in time, those were actually glue injected to stop them. At the hospitalization that these images were acquired on, he presented with melena and some question of hematochezia. And so he underwent colonoscopy and upper endoscopy. The colonoscopy was negative for any potential source of bleeding, and the upper endoscopy only showed his previously injected gastric varices. And again, no evidence of active bleeding. In the hospital, he continued to have melena and then had an acute drop in his hemoglobin, and so his primary service ordered a CT angiogram. And we'll look at that here in Part A. And what we see indicated by the arrow is a fairly large pseudoaneurysm, and that's arising from the left gastric artery. Nearby, indicated by the arrowheads, is a large hematoma. And so this patient had melanoma maybe from some other bleeding site in his GI tract, but his acute drop in hemoglobin was due to an extraenteric bleed here associated with this pseudoaneurysm. And this highlights a really important and helpful aspect of CT angiography in patients who are complicated or have confusing histories. Not only are we going to evaluate the entire GI tract within the abdomen and pelvis, but we also get a chance to look at all of the solid organs, and we get a chance to look at other bleeding sites such as the retroperitoneum or the abdominal wall. And so in this case, that really was a big helpful, very helpful to the primary team. They ended up going on to fluoroscopic angiography where the pseudoaneurysm was again seen and embolized.
Terrific. Thanks, Michael. So in the section on CT, you discussed the use of dual energy CT acquisition techniques and their particular advantages in this clinical setting. Can you review how dual energy CT can be used in the evaluation of GI bleeding? And we'll take a look at figure 4, which is a nice example of dual energy CT in a patient with hematochezia.
Mm-hmm. So dual energy acquisition is our default protocols here. So for our CT angiography protocols, we're acquiring data in both an arterial and a portal venous phase. And we'll acquire the portal venous phase as a dual energy sequence. In the for multi-phase CT angiography, we're acquiring data in an arterial, an enteric, and a delayed phase. And we'll acquire that delayed phase dual energy. The major benefit of acquiring dual energy for this is to avoid having to acquire a non-contrast scan and therefore lowering the radiation dose of our CT scans. We can generate virtual non-contrast reconstructions, and then we can use those to look for any radiopaque foreign bodies that might be in the bowel lumen or associated with the bowel wall that we might erroneously diagnose as active bleeding or enhancing pathology. And so hopefully we'll decrease the false positive rate of our exams. An additional benefit of these dual energy acquisitions is that we can do other reconstructions such as iodine only or iodine maps and virtual monoenergetic reconstructions. We reconstruct our virtual monoenergetic series as a 50 keV. And the major benefit of those sequences is that we're going to highlight any pixels that we think have iodine in it, and we're going to increase the conspicuity of active extravasation or enhancing pathology in the bowel wall. In this example here, figure 4, what we have is an 84-year-old female. She had pancreatic diverticulosis, and she presented with large volume painless hematochezia to the ER. So right in the ER, they ordered a CT angiogram. And in part A of the figure, what we see is high density material accumulating within the descending colon adjacent to a diverticulum. And we compare that with part B, which is an iodine map. And so we can easily see here that high attenuation material is extravasated iodine, and it's not just a radiopaque foreign material. In that same patient, here in part C, we see again high attenuation material within the lumen of the small bowel. Comparing with a virtual non-contrast scan in part D, that material persists. And so that's non-iodine containing just foreign material, and it's an incidental finding, not active extraction. This patient went on to get a colon prep and colonoscopy. Fortunately for the colonoscopist, we could tell them where the bleeding was from. And so they're not sorting through dozens and dozens of different diverticula trying to find the site of bleeding. They can localize it to an anatomic segment of the bowel where they can then do a targeted exam. They were able to find the bleeding diverticulum. They attempted to place a clip here to stop it, but the patient unfortunately developed recurrent bleeding. They went on to fluoroscopic angiography again. They knew right where the bleeding source was, and they were able to embolize it.
Great, thank you. So, Michael, your paper goes on to briefly review the role of multi-phase CT enterography in stable patients who have had negative endoscopy and in whom there's a suspected small bowel source of bleeding. And you provide your protocol for our readers performing CT enterography in Table 2. You also discussed limitations of both CT angiography and CT enterography in the evaluation of GI bleeding, which it seems are primarily the time required to perform and interpret the study, and obviously the use of contrast, neither of which are really prohibitive, but are limitations. The paper then reviews some of the CT findings that you're encountering in these patients, which you divide by the upper and lower GI tracts. Figure 8's a very nice example of the CT findings with endoscopic correlation in a patient with an upper GI bleed. Can we review this case and the CT angiographic findings that I illustrated here?
Yeah, so this patient, this was a 70-year-old male. He was anticoagulated for lower extremity DVT, and he presented to the ER with melena. When he got to the ER, they found that he had a recent and new drop in his hemoglobin. In addition, he was also complaining of some vague upper abdominal and chest pain. And so they were suspicious this was an upper GI bleed, but rather than go to upper endoscopy, primarily due to the abdominal pain, they ordered a CT angiogram for evaluation of both the pain and the bleeding. And here what we see in part A is the arterial phase of that exam. The dashed arrow here is indicating the gastroduodenal artery, and the arrowhead right next to it is showing a small vessel coming from the gastroduodenal artery and feeding the duodenum. The solid arrows next to the arrowhead are showing a nidus of arterial hyperenhancement and a small focus of contrast accumulation within the bowel lumen. And so the radiologist that interpreted this exam appropriately was suspicious of an arteriovenous malformation with these imaging findings and suggested this is a person who really should go on to upper endoscopy. The upper endoscopy was a little bit delayed in acquiring, but when they did it, they found this, what's in figure part B, which is an ulcer with a clean base. And importantly, the endoscopists at this time noted that they didn't see any sign of active or recent bleeding when they did the scope. But putting that together with the CT is very helpful because we know we've already shown that they're bleeding from this location. And so without the CT, there might have been suspicion that this was not his source of bleeding. He could have gone on to further evaluations to look for sources of bleeding elsewhere in his GI tract. But instead, he was just observed. He didn't have any more bleeding episodes, and a follow-up endoscopy showed that this ulcer had resolved.
Terrific. So moving on to the lower GI tract, aside from the usual anorectal lesions as common sources of lower GI bleeding, we're dealing primarily with the diagnoses of diverticulosis and arteriovenous malformations. Let's look at figure 12 and review the findings in this particular patient who was found to have an AVM.
Yep, so diverticulosis is by far the most common cause of bleeding in the colon. Vascular malformations are relatively less common, including AVMs. AVMs, though, are important because they can be missed at endoscopy. When we see them, they're most commonly in the cecum and in the rectum. And we're going to look at our arterial phase images to try to find these lesions. In this case, this is a 58-year-old male. He presented with hematochezia. He did undergo a colonoscopy, which only found a few polyps in the colon. And they actually ordered the CT with suspicion that he had a small bowel lesion. And here, as you can see in the figure here, we've got a vascular abnormality in the cecum. And so AVMs, the findings we expect to see would be a feeding artery with a central nidus of enhancement with or without active extravasation. And since there is no capillary network associated with these, opacified blood is rapidly shunted into the venous system. And so when we look at this figure, the arrowheads here are indicating the feeding artery, and the solid arrows here are indicating the vein. And you'll notice that in the arterial phase, the vein is actually a little brighter than the adjacent artery, and it's relatively dilated, which are both characteristic findings in an early draining vein. A lesion that could look similar to this would be like a Fly lesion. Oftentimes we don't see anything other than active extravasation with those. When we do see them, again, we'll see a feeding artery with central nidus of enhancement. But in that case, there's a capillary network present. We do not see these early draining veins.
Great, thank you. So finally, in your paper, you touch on the issue of detecting sources of small bowel bleeding, which can be a difficult area, obviously, to evaluate endoscopically. Perhaps you could just review for us the role of Ct angiography and multi-phase Ct enterography in this particular setting. And we'll look at figure 15, which I think is a nice example of the use of multi-phase Ct enterography in this particular setting.
Mm-hmm. Yep, absolutely. So after patients who are presenting with bleeding and they've had a negative upper and a lower endoscopy, they're then said to have suspected small bowel bleeding. And the vast majority of those patients we would like to get to multi-phase Ct enterography to get an optimal evaluation of their small bowel and look for any pathology along the bowel wall. Now, some of those patients might have their upper and lower endoscopy and then present with recurrent bleeding. And if rapid and they're at risk for decompensation, we need a quick evaluation. And in those patients, Ct Enterography is the most appropriate test. In this particular case, this was a young woman. She presented to an outside ER with large volume hematochezia. They obtained a technetium labeled red blood cell scan, and the results of that scan on the initial interpretation were inconclusive for a source of bleeding in either the small bowel or colon, but it was able to confirm that she was having active bleeding. Based on that, she was transferred to our institution. Our review of the red blood cell scan, we were more suspicious that this was a small bowel source. And in addition to that, our gastroenterologist got some additional history that her father had a history of a small bowel neoplasms removed. And so based on those two things, we're highly suspicious that she also has small bowel pathology. And the decision was made to go ahead and perform a multi-phase Ct enterography to optimize our evaluation of the small bowel. She had that test done, and here on part B of this figure, you can see that she's got a well-circumscribed hyperenhancing mass. It's originating from the small bowel in her pelvis. You can also see that she's got large abnormal vessels coursing along the wall of the adjacent small bowel. And in part C, we're showing that she actually had active extravasation that you can see clearly on the CT scan. Because of all these findings, we've also surveyed the rest of her abdomen, having obtained the CT scan. We were able to confirm the absence of any metastatic disease in the abdomen. Our gastroenterology and surgery teams were happy with this amount of information, so they ended up avoiding a colonoscopy to work up lower GI bleeding. They didn't go to fluoroscopy. They ended up going straight to the operating room. There they were able to resect the tumor here, and this ended up being confirmed as a gastrointestinal stromal tumor.
Terrific. Well, Dr. Michael Wells, I want to thank you for taking the time today to discuss your paper, which deals with CT angiography and multi-phase CT enterography in the evaluation of acute GI bleeding, which can be found in the current July 2018 issue of RadioGraphics. Michael, thanks so much for everything.
Yeah, happy to be here. Thanks for having me.